Do you guys have any questions? Any questions from yesterday? We'll finish up room today, and then we'll see how much time we have, and I might start on the next section because endo's kind of pretty long. There's a lot of stuff with diabetes to talk about, so I might need the extra time there. I did forget to tell you about, there was actually a medical error that happened. It's a good lesson for you guys to know about. That happened recently. A patient got the wrong kind of blood. Yeah, the chart said it was type A, but unfortunately it ended up being a type O. All right. Anyway, so continuing on with our talk of, we talked about rheumatoid arthritis. We talked a lot about the DMARDs that we'll use for those patients. Certainly we'll use acetaminophen, probably not so much for the RA patients, but definitely for the OA patients, we'll get this more commonly. This is a really good initial first choice for a lot of patients. Why do you think that is? Why is this, like acetaminophen, the drug to go to? Yep, very few side effects, which is a good thing. What else? Anything? Over the counter. Cheap for the most part. You can go to Costco and you get like a 1,000 count bottle that can kill like the whole classroom practically, and for like $5 it seems like. It's insane how much they can pack in one bottle. But anyway, you're gonna find they'll be kind of modestly effective. It's better for kind of more mild to moderate sort of symptoms here. But again, it's nice because you don't have any of the toxicities you see with the NSAIDs. However, the one toxicity you should worry about is the liver stuff, right? So you got to watch out for liver things. What's the max amount that you should receive in a day? 4 grams is what they recommend. And actually, for a lot of patients, especially for patients who are kind of like self-dosing at home, self-medicating, they'll actually recommend a lower amount. So they may say like 3250 in a day. And the whole point of that is because even when you take 4 grams every single day, as some of these patients will, you can still find some rises in their LFTs. You can find some chronic sort of damage is being done to the liver over time. So you do want to be careful with that. Typically these patients, you want to start with scheduled therapy, especially around the times when they know that their joints are going to be a little bit more painful, in the morning, things like that. But the nice thing, relatively safe. Watch out with hepatic toxicity, and especially if you have anyone who has concomitant liver disease on top of being on something like warfarin. And that's really important because warfarin's working where in the body? Yeah, so it blocks the activity of vitamin K, but does that where? In the liver, right? So again, it would kind of make sense that if acetaminophen screwing up your liver, maybe warfarin, where it's working in the liver as well, can be can be impacted there additionally. And actually, when you say liver function test, like you think about your AST or ALT, actually that's not really a good marker of function, right? Because you can have patients who have 0 LFTs essentially, and their liver just not functioning at all. Once they're kind of or have no more enzymes to release, like that's kind of it. What's a better marker to look at for actual function of the liver? Since we're talking about warfarin. PT-INR. Look at the PT-INR. That's going to be a really good marker. And actually, that's one of the things we'll look at when you're dealing with Tylenol toxicities. We'll see a patient who will come in, say 24, 36 hours after they have overdosed on acetaminophen. Their LFTs will start to rise, which is a good marker for some damage being done there, but it doesn't really tell me how good the liver's function. Once I start to see the PT-INR go up on those patients, I know they're in big trouble, because that shows me that the liver's not making clotting factors like it should be, and that can be a pretty bad sign, right? So in some of those patients, when they get really kind of fulminant hepatic failure, the LFTs will start to dip back down, and you think, oh, everything's good, the LFTs are going down. No, it's probably actually a bad thing if the PT-INR is still going up. So just be cognizant of that, and that's one thing you may see being checked on if you have a patient with really severe liver disease. That's also why they may get vitamin K occasionally to kind of help supplement that. Anywho, so we'll talk more about pain stuff when we get to the orthopedic section. It'll be coming up pretty soon here. So we'll talk about some of these meds there additionally. Now, as far as topical agents go, what do you think are some of the benefits of using a topical drug? Yeah, less systemic toxicity. What's some of the drawbacks? You'll still see they can be pretty potent at the site, but the problem is if they're having kind of more diffuse disease, right? There are many joints are being affected, then you can find that it can be difficult to apply them to all those areas, right? So if it's only say the hands, like maybe reasonable to apply it there, but if it's the hands and the knees and the hips, and it kind of gets a little bit more cumbersome at that point. That's why they may prefer more systemic therapy. The other thing is having to apply topical products is usually not the most, it's easy to take a pill and you're kind of done with it. But if you have like, kind of a greasy film left over from some of these medications and things like that, you can have drying effects that occur there. It may not be quite as convenient for the patient. So that's one thing to consider. So typically we'll recommend topical products, and we'll talk about some topical NSAIDs we can use here as well. If acetaminophen has failed for these osteoarthritis patients, and then we actually prefer these over NSAIDs for those that are greater than 75 years of age, because we worry about those toxicities that are associated with that, namely things like GI toxicity, worry about bleeding risk, things like that. The two big ones that we have available is called diclofenac or Voltaren gel. You see that one used pretty common. That's actually a prescription product, but for whatever reason, if you go if you go on a cruise and go to trying to think, what's the port you usually go to? Nassau, right? All right. Yeah, that sounds right. Nassau. You can actually get it there over the counter. So if you ever go to the pharmacies, you can grab that. My wife is very excited, for little minor aches and pains and stuff. So it's good not just for osteoarthritis, but any kind of like sprains and aches, whatever it happens to be. There's also salicylate-based products. There's like Aspercream. That one would be available over the counter. So that one could be another option that's easily available to your patients. So other products, you have capsaicin. Where do you find capsaicin at? Hot peppers, absolutely. So the idea here is these are actually stimulating those nerve fibers to try to release things like substance P. And basically, when you deplete the nerves of substance P, they kind of get a little bit more deadened, and so they don't really transmit those kind of pain signals like they would normally. So as you might imagine, when you apply this to the skin, what do you think it might feel like? Feels kind of hot, right? So initially it can be kind of uncomfortable for the patients, but as they apply it pretty consistently over a period of time, days to weeks, you're going to start to see that fade away, and it's actually pretty darn effective. The problem is that compliance is not super great. You're going to find that a lot of patients will not stick with this like they should. Other big products you can see with capsaicin, again, you have to apply it pretty frequently, 2 to 4 times a day. It can be hard for the patients to keep up with. Anyone ever chop up like a jalapeno and then accidentally you subconsciously go to rub your eye? For whatever reason, it's like my eye didn't itch all day except for when I'm cutting up this jalapeno, and then what invariably happens? It burns like a mother, right? You got it, like, it really, really hurts. Same thing happens with capsaicin. It really is important that they wash their hands very, very well after applying this, or if they use gloves, that would be actually preferable, because you don't have to worry about it getting cross-contaminated with those mucous membranes, because it can get very, very uncomfortable for your patients. Anyone know how to treat that? Milk is actually really good. Why is milk good? Has the lipids, right? It has fat. You need to use like whole fat milk is really good, because it will allow that capsaicin to partition into the fat layer, and then it can be washed away. So other things you could use, things like olive oil and kind of cooking oil, things like that are actually really good. I had one patient who called up, and she is at the Poison Center, and I can't remember what the product was. I think it was probably like, actually it was pepper she was cooking with, but basically she was having just really bad, like her skin was just like on fire, and she was like could not figure out what to do. The skin was getting all turned on purple practically from all this, and so I was like, oh, well, go ahead and dunk your hand in some olive oil. She's like, what the heck is that gonna do? That's crazy. Did it, and then called back 30 minutes later. She's like, it totally fixed it. It's great, because all that capsaicin just partitions out to the fat layer, and then you're done, which is really good. So you can do that. Does anyone know the scale that they use to measure the hotness of a pepper? The Scoville, yeah, so it's a little fun piece of trivia. So they measure peppers, and how many ever millions of Scovilles it has. Yeah, so capsaicin is very good, but again, compliance is not super great with this one, so should be aware of that. There's other ones. There's counter irritants. These kind of draw the pain away by causing either like a cold or kind of hot sensation. Again, kind of variable efficacy with these, but you may see things like menthol, camphor-based products, or oil of wintergreen. Not used probably as commonly, but again, you can get a lot of your bang for your buck out of capsaicin if you apply it regularly. But the patient needs to know to do that. Otherwise, they'll kind of stop after a while, and then those nerve fibers will develop more substance B, and then you're right back where you started. Okay. Next, we have intraarticular corticosteroids. These are also really good for like knee and hip osteoarthritis. If it's uncontrolled by NSAIDs or acetaminophen alone, you really should not administer it more than every 3 months, because we talked about that earlier. You can see things like tendon atrophy. You can see some issues with the joint itself. So would not recommend any more than that. But when it's injected in there, it's very, very effective at dealing with that inflammation seen with the osteoarthritis. So very, very effective, but cannot use it too often. All right. Opioids, we'll talk a lot more about opioids in the orthopedic section that will be coming up. These are going to be not ever first line for osteoarthritis. It can be used as kind of a backup method, especially for more kind of short-term kind of pain control, because what do we worry about with opioids? develop dependence on them. If you use them chronically, you can develop addiction secondary to this, and so it's a big deal. In fact, a lot of places are getting more stringent about how they are prescribing opioids, and so it is getting tighter leashes on that sort of thing, and so we'd like to really hold off on using these as much as we can. We'll talk much more about these in the ortho section. It'll be coming up. Okay. Glucosamine and chondroitin, is this a prescription drug product? No, it's actually a dietary supplement. So this is the few times that I'll talk about dietary supplements like that in like St. John's wort. So I don't cover them often, but when I do, it's usually because they have some documented efficacy, and you'll find a lot of patients are going to be using these. Sorry, that's very unprofessional on my phone. Turn that on vibrate. Anywho, so we find glucosamine and chondroitin that's actually found in the cartilage and in synovial fluid, and so it's thought that by administering these, and these are typically given orally, they will help to increase proteoglycan synthesis within the cartilage, and hope to help kind of maybe not repair it completely, but hopefully maybe slow down progression a little bit, maybe help to improve some function and prevent further breakdown. And you find actually some decent modest effects in conjunction with other kind of pain control sort of medications, along with physical therapy and things like that. And so I would definitely recommend it. It's not going to be too from a side effect standpoint, it's very well tolerated. So it's really very little to lose for a lot of patients to take this along with their other medications for osteoarthritis, and it can actually help to hopefully stave off disease a little. Get relatively safe. Most studies have been done in knee osteoarthritis, but there's nothing to say that it couldn't be used for like hip or hand osteoarthritis. So you can use that as well. However, you will find that you want to be careful with the shellfish allergy. The chondroitin, I believe actually the glucosamine is the thing that can have a cross sensitivity with people with shellfish allergy. It's made from actual seashells, so you can find some issues with that. So again, be careful if they have that allergy. You may want to avoid that medication there. But it does come as a dietary supplement. So what are kind of the regulations on dietary supplements? Does anyone come in and say like it has to make sure you have this many milligrams of glucosamine, this many milligrams of chondroitin in it? Not really, right? It's not as well regulated from that standpoint as you would see like the FDA would for typical like prescription drug product, right? Basically, what it comes down to is that if a supplement is thought to be harmful to people, and there's like reports of things like liver failure developing. So you guys remember Oxycut? It's like a popular like weight loss sort of supplement that was around for a while. It probably still is around as a brand name, but there were some versions of it that were actually causing liver disease secondary to one of the ingredients that was in it. And so once they get reports of this, then the FDA can come in and say, hey, we need to look at the safety effects of this. And when they look at that, see if it's dangerous, they can pull it off of the market. But they really don't have to come in and say, well, it has this many milligrams of glucosamine, this many. So you can get a lot of products that are of dubious quality, I would say, most nicely, as I can put it. Make sure they're going to use a consistent brand, and make sure it's not going to be like they're buying it out the back alley of a Walmart or something, like a little bit nicer brand. You kind of get what you pay for a little bit. So it's okay to get the the little bit nicer version. Maybe the Publix brand is probably okay to give. Not that I have stock in Publix, but man, if that ever goes public, I'm buying it up. Anywho, all right. We can also use hyaluronate injections, and so this is actually some intraarticular injections as well. Used typically, you see a lot of knee osteoarthritis where you're going to use this most commonly, and hyaluronate is actually a constituent of synovial fluid and has some anti-inflammatory properties, and kind of help to replace this as it kind of is going to be depleted in a lot of these patients. We do find that it helps to improve joint mobility, helps with the pain issues they're experiencing, and you can actually give it over a course where you basically give say one injection once every week for 3 to 5 weeks or so, and again it's relatively free of side effects, so it's nice from that standpoint. This one you can give more often. You don't really see the same issues as you would with like an intraarticular corticosteroid, so no issues from that standpoint. Okay, so looking at how you go through and manage these patients from kind of a flow chart standpoint, I feel these are usually pretty easy to follow. But for hip and knee osteoarthritis, you're going to find that typically start off with the easiest drugs, the most side effect free drugs you can. Start with something like acetaminophen is going to be most beneficial. Again, we're going to go more into details on some of these pain medications in the ortho section, so just kind of keep these in the back of your mind as we talk about them. But if they can't receive acetaminophen, then no, they should probably start on that. No more than 4 grams a day. Again, they would probably need a lower dose if they have history of liver disease. So just be careful with that. Otherwise, you can use things like topical NSAIDs. Again, trying to use things that are going to limit those systemic side effects. So topical NSAIDs are good for that. Intraarticular corticosteroids. And anyone ever heard of tramadol? You know what kind of drug that is? It's not a seizure drug. It's topiramate. actually can cause seizures, but we will talk about that in the ortho section. But it's a kind of a partial opioid agonist, so the kind of think of it as like the wimpy cousin of like oxycodone or something like that. We'll talk about that later. That can sometimes be used as an alternative for pain management for these patients. So again, we'll get into much more detail on that in the next set. And we'll have oral NSAIDs can be utilized, but we really prefer to use those if they're less than 75 years of age. Also, what's the other thing that what can NSAIDs do to your kidney function? It can decrease, right? If I am asking questions, probably because it's not going to. Oh, it's actually great for kidney function. No, it's not. It'll decrease kidney function. It's again goes back to that prostaglandin effect on those arterioles, right? Remember that afferent arteriole heading into the glomerulus. Those prostaglandins help to keep that open. If I give an NSAID, those prostaglandins go away. It's going to constrict down, and that can decrease that GFR. So again, you have to be careful with that for those patients who have existing, renal disease, or they really kind of depend on those prostaglandins for that renal function. So again, another risk with using the systemic NSAIDs. If it's effective, great, continue treatment. However, for a lot of patients, they may not get full relief from that. This is when you consider things like short courses of opioid analgesics. Again, not to have something on board all the time, because again, we're going to see some issues with that. Surgery, obviously, is going to be a good thing. And we'll look at duloxetine. Remember duloxetine? What type of drug that was? It's not SSRI, it's SNRI, right? Remember, Cymbalta is the brand in there. So it has some norepinephrine effects with that one. That one has some evidence for being used with knee osteoarthritis, but again, it's not going to be a first-line agent. It's going to typically be something you might use as a second or kind of third line. Maybe it goes back to some of the neuropathic pain issues. We'll talk more about neuropathic pain in the next section as well. And then also looking at intraarticular hyaluronate is another good option for these patients. So again, start with the easiest stuff, start with the things that have the least amount of side effects, and then kind of go kind of a stepwise approach from there, right? But just hand osteoarthritis, you can kind of divvy this up based on starting out with their age. So if they're greater than 75, again, you want to avoid things like, oral NSAIDs. You can use topical NSAIDs instead. So like a Voltaren gel would be good for them. You can try using the capsaicin. Tramadol is also another very good option for those patients. On the flip side of that, if they're less than 75, they can probably receive NSAIDs unless they have, some contraindication. And so they can also utilize topical NSAIDs as well. So you can actually use both at the same time. There's really no risk for having kind of additional systemic side effects from that. And capsaicin, and unfortunately, there's not really surgeries are not really a good option for hand osteoarthritis for these patients. And so, again, you can continue to think about kind of alternative regimens. Sometimes using two first-line agents at the same time, multi-drug regimens may be effective for some of those patients. But okay, so any questions on osteoarthritis, rheumatoid arthritis? So again, if I have a list of, as I say, if a patient presents and they have, history of osteoarthritis and they need something for their pain control, and I have, say, acetaminophen, infliximab, Percocet, and then something else. Your job is to kind of go through and go, okay, what's going to be most appropriate for this patient? Again, look at see it's osteoarthritis. No, there's no really point in using a DMARD. Acetaminophen is probably a good option for those patients, right? So again, it'll be kind of selecting which drug is going to be best for that patient, or if they fail one drug, what's a good thing to go to next? Those are good test questions that could come up. Okay, moving on. We next have osteoporosis and osteomalacia. So have you guys covered this at all already? So what's our treatment of choice for osteoporosis? The class of drugs we use? The bisphosphonates. It's funny, my little girl, she's starting to, she can't really enunciate a whole lot of words very well. So I'll say, like, you can say please, and she goes, and so I kind of feel like that's when I say it with you guys. I'm like, okay, what's the drug? And you're like, yes, bisphosphonate. That's it. I know what you meant. That's it. Perfect. It's just fun to find those little parallels. Not that you guys are kids, but you're very young in your medical career, so you're just learning the vernacular. You're getting much better at it. She also learned to say quack recently, which is very cute. So anyway. So all right. So I'm gonna read this whole slide. So osteoporosis, right? What's the issue with osteoporosis? Fracture. Yeah. So that is a consequence of osteoporosis. What's kind of the background issue with it? Decreased calcium deposition in the bone. Good. Increased osteoclast activity, right? It's going to be an issue with some of these patients. You're going to see increased osteoclast activity that'll help with bone resorption, right? So you're helping to liberate calcium. Decreased osteoblast activity is going to be another big thing. So when we're looking at the drugs we're going to use here, they're going to be trying to focus on those pathophysiologic issues, right? So they're going to try to decrease the osteoclast activity, increase the osteoblast activity to try to increase bone deposition. You guys know what other organ dysfunction causes a lot of issues with the bones? Yeah, thyroid can be more like a parathyroid. See a lot of issues with that. Kidney is going to be a big one. Chronic kidney disease. See a lot of issues with renal osteodystrophy is what they call it. You guys heard of that yet? Yeah, so you see a big issue because we'll see that in addition to calcium, what else do you need to help with getting good calcium absorption from the GI tract? You need vitamin D. And where is vitamin D activated? In the liver, and then the final steps in the kidney. So you see, if you have kidney disease, you're going to have issues with vitamin D. So we'll look at that, look at some options to get around. I know we've kind of covered this, somewhat, at least in the physio course, but this will come back around, especially when we talk about the nephro stuff later on. Anywho, they're going to have this impaired bone or low bone density. They're going to have kind of an impaired bone architecture, and so you're going to see more likely to see these fractures that develop here. And again, fractures can be huge, especially for these older patients. Huge impact on their quality of life, on their ability to get around. You see a lot of increased mortality secondary to patients developing these hip and bone, especially like femur fractures and things like that. So you got to be really careful. And if we try to prevent this, obviously it's going to be better for our patients. So what are some medications that are associated with osteoporosis? And so I'll highlight just a few that we've kind of talked about with the kind of putting the greatest emphasis here. Again, things like aromatase inhibitors. Remember what those were doing? They don't antagonize the estrogen receptors. What do they do with estrogen, though? They decrease levels of it, right? Because you need aromatase to help that conversion to produce estrogen. So if you have an aromatase inhibitor on board, you actually would have decreased estrogen levels. And we know that especially when women have menopause, they have decreased estrogen levels, and that means they can develop osteoporosis, right? Because they have less estrogen effect on the bone. And we talked about the SERMs as well. We saw that things like tamoxifen wasn't really good for the bones because you can see that it would have antagonistic effects on the bones. That's not good from an estrogen standpoint, but something like raloxifene would be okay. So we'll look at some examples of those. Things like glucocorticoids, we know that chronically you can certainly see risk for osteoporosis develop. Again, that's going to help to impair, kind of good bone turnover. You're going to see more of the osteoclast activity that happens there, so that can be a big issue. Especially because, again, who do we say is going to be getting long-term corticosteroids? Someone with rheumatoid arthritis. So again, this could put them at a bigger risk for developing osteoporosis, right? And that if they're getting older, females getting menopause, you can start to see how some of these things can kind of snowball on one another, and why it's important to try to head this off early, try to keep that bone density as high as long as you can. Other things like proton pump inhibitor. How do you think this might affect osteoporosis? So proton pump inhibitors, you talked about MGI.
Worsen osteoporosis. Worsen osteoporosis.
How would they do that? So what is it? So what would a proton pump inhibitor do to the stomach? Decreases acid production, right? So the pH would do what? Would go up, right? So you see the pH of the stomach go. That actually will impair calcium absorption. Calcium actually gets better absorbed in a more acidic medium. So you see chronically, if you have a proton pump inhibitor increasing the pH of the gastric fluid, you may have impaired calcium absorption. So that is one thing to consider kind of long-term PPI use. And again, think about someone who has rheumatoid arthritis and are on NSAIDs chronically. They may be at risk for developing NSAID-induced ulcers, which we'll talk about in GI. They're going to be on PPIs for, a lot of them are going to be on PPIs chronically. So you can see issues with that. Again, exacerbating the osteoporosis. So again, just kind of these things, how they can lump, one thing on top of another. You're treating one side effect of one medication, but then you're worsening something else down the road that we have to treat with other medications. And you can start to see how some of these patients, when they have these, have you guys ever heard of a brown bag event? Where they go to the nursing home and you have them bring out all their medications, usually in a big brown bag or Walmart bag or something like that, and they just lay out 40 pill bottles, and your job is to try to go through and figure out okay, what are you still actually on, which of these are not expired, but they'll be on 15 meds at a time, and again, a lot of it could be related back to treating side effects of other medications, which is not ideal. Certainly some other things, we'll talk about some of these other medications, but how do you think furosemide may increase risk for osteoporosis? You're peeing out your calcium, right? So you may not have calcium there. Also, if you think about things like fracture risk, if you are taking a diuretic, that obviously means you have to do what? You have to pee more, right? So you have to get up to go pee. And if they get up and they fall, that's a risk, right? So diuretics, can be associated with fractures due to that effect. Having them get up and go to the bathroom in the middle of the night. It's dark, they're already dizzy to begin with, they have some orthostatic hypotension, they trip and fall, and then boom, they got a fracture, right? So again, some of these things are definitely multifactorial, but it kind of makes sense when you kind of think through the whole process there. Anywho. So we said that we have, you know, this balance between the osteoclasts, which are kind of liberating calcium from the bone. We have osteoblasts, which are laying down new bone, and they can be affected by many things that we've already alluded to. Estrogen being a big thing here is going to have kind of pro-bone sort of effects, pro-laying down calcium. Testosterone can affect this to some degree, and parathyroid hormone. What does parathyroid hormone normally stimulate? Yeah, so bone resorption, right? So it would actually stimulate osteoclast activity. So if you have hypocalcemia, the parathyroid picks that up and says, "Hey, let's release PTH," and that will help to release more calcium from the bone, right? So you think about those kind of negative feedback loops and how that can affect these. And again, we'll look at some drugs that actually can directly will directly affect PTH, especially in patients who that's already kind of upregulated in. But again, when you have osteoporosis, you're favoring that bone resorption. You're going to have kind of more weak and brittle bones. That's what we want to avoid. So calcium homeostasis is also maintained by vitamin D. Vitamin D is very important here to help with especially GI tract absorption of calcium, and so also with renal reabsorption. So parathyroid hormone not only will help to liberate calcium from the bone, but it also will stimulate the kidneys to try to hold on to more calcium. Vitamin D can also help with this as well. And remember that normal vitamin D you would take, say, in your diet or that you would get from a tablet is not typically the activated form, right? Even the one that your body produces from sunlight. You guys, actually, it'd be funny to do a study to see if like you guys have like better vitamin D levels than people on the other side of the room. But yet, it's kind of baking for a little while. But you're going to find that even that form is not fully active. It has to go and get the first hydroxy added on in the liver, and then we'll have the second hydroxy group added on in the kidneys. And that's the actual activated form that is going to be useful to us. And so we mentioned if you have renal disease, you can have issues with that and not have an activated, not be able to produce activated vitamin D. So we'll have to get around that by giving the activated form. So you see calcitriol, that's what we're referring to, is that 125 dihydroxy vitamin D. That's the active form that we want to give those patients. Anywho, so we have low calcium levels that will help to stimulate the parathyroid hormone, as I mentioned, and that's going to stimulate not only calcium reabsorption in the kidney, but we're also going to have osteoclast activity being increased. So again, that's the big thing we're going to be trying to inhibit there. And then we mentioned estrogen deficiency also will stimulate osteoclast activity. So our goals is try to prevent prevention is obviously going to be the best thing here because once they had that fracture, we're kind of behind the 8 ball in a big way. So prevention is going to be the primary goal. And once they already have kind of low bone mass, we want to try to stabilize that as best we can and obviously prevent fractures from occurring. So again, I'm not going to get into the diagnostics of it and doing Z-scores and all that kind of fun stuff, but we'll just talk about someone who has osteoporosis. How would you manage them? Once the fracture occurs, then obviously we want to deal with the pain issues. A lot of these patients will develop chronic pain issues after this, and that can be a big deal. Try to improve their functional capacity, and then obviously prevent future falls and fractures. That's going to be a big goal there as well. So non-pharmacologic therapy. So typically calcium and vitamin D needs to be supplemented for these patients. They're going to need higher than what they would normally get in their typical diet. And again, their diet may be not really great to get these in sufficient amounts anyway. That kind of led them to get osteoporosis in the first place. But calcium usually you can take it in as calcium carbonate. So Tums is a very common way for people to take this. What else can you use calcium carbonate for? Use Tums for? Yeah, you can use it as an antacid, neutralize stomach acid. So, again, these patients, maybe using these already as kind of a self-medication for GERD type symptoms, but anyway, this is a good way they can get it in. There are other forms that are available as well. Just need to make sure that you're doing it based off the elemental calcium amount. So that's one of the things you'll find, especially with iron preparations or calcium preparations, is that they will have the salt form that is being listed. So calcium carbonate is the salt form, and then they'll have what they call the elemental calcium amount. All right, so for instance, 1250 of calcium carbonate is actually 500 milligrams of elemental calcium. So the important thing to know is if you're switching between different salt forms, that elemental calcium amount needs to stay the same because you could goof it up. You could be either getting too much or too little. That becomes important, especially for iron products, between like iron sulfate versus iron gluconate and all kinds of different salt forms that are out there. So again, watch for the elemental iron content or elemental calcium content. Usually that'll be listed on the label, right? That makes sense? Okay. As far as adverse drug reactions go, constipation is going to be a big issue with calcium. Obviously, hypercalcemia could be a risk there, and then nephrolithiasis. So if they have any history of kidney stones, this could be worsened by giving them additional calcium. Also, you need to separate these out from other medications because you can have some binding that happens here. So think about things like thyroid supplements can bind it, fluoroquinolones, so again, going back to our antibiotics, which we haven't talked about in a while, but tetracyclines, and then we'll find bisphosphonates, which we are going to use for osteoporosis as our kind of gold standard of therapy. That'll also be impacted as well. Bisphosphonates, we'll talk about those having a lot of dietary interactions to watch out for. But again, separate them out at least by an hour or two. So maybe take the medications that can bind maybe an hour before the calcium or maybe 2 hours after, and that will help to eliminate some of that binding issues. Vitamin D, typically anywhere between 800 to 1,000 units a day is typically pretty good. Can you overdose on vitamin D? Yes, you can. Fat-soluble vitamins you can't overdose on chronically because the body holds on to them for longer. Your water-soluble ones you just pee out typically, right? So think about you drink a big Monster. What does your urine normally look like afterwards? Monster Energy drink. Usually looks like neon green, right? Because you're peeing out all the B vitamins and taurine and all that kind of good stuff. But on the other hand, fat-soluble vitamins you do hold on to for a little bit longer. But anyway, it's a random tangent. But anyway, you should be getting vitamin D in. And again, is this the active form that they're intaking typically? No, it still has to be activated in the liver. So if they have liver disease, it's not going to happen. If they have renal disease, they're not going to get that second step. So both of those need to be in play here. And again, if we do have those issues with hepatic disease or renal disease, you can give the activated forms. So for instance, if they have liver disease, you can give them calcifediol, which is used occasionally, and then a lot of patients will need calcitriol if they have kidney disease. So we'll get more into that when we get to the nephro lecture. Just know that they have those impairments and may not be able to activate the vitamin D themselves. Right? Okay, so oftentimes medications needed to either prevent or to treat the actual osteoporosis and that decreased bone mineral density. And so we're going to find that prescription therapy is going to be needed in a lot of kids. Certainly, if they're premenopausal, if really anyone should be getting their calcium and vitamin D in sufficient amounts. But they're older than 50 years of age. If they've already developed actual osteoporosis based on based on diagnostics, they look at things like low bone mass with 10-year probabilities of having a fracture. That could be another indication to treat there. Or any kind of fracture. So if they have a high enough risk, then we'll go ahead and start treatment early to try to help to prevent it from developing in the first place. So we talk about our anti-resorptive therapy, which is just saying things that help to keep the calcium in the bone, keep it there as long as you can. Does anyone know which heavy metal looks just like calcium to the body? It's important for people that live in older houses. Lead, yeah, actually lead looks a lot like calcium to the body. So that's why you find issues with especially with younger kids who live in older houses, or if they live in areas where especially if they don't get really good calcium supplementation, vitamin D supplementation in the first place. They actually find that they tend to hold on to lead a lot better, and lead ends up going where? To the bone, yeah. So you can actually see lead lines. You can Google that. You can find lead line pictures for kids who have been exposed to that. Because again, who has the most developing or the fastest developing bones? Children, right? Because they're actively growing, so they'll have a lot of that lead that gets deposited there in the bone. That's why it's so important we do lead screens, and especially they live in older houses and things like that. Actually, I had a really good case of a family. This is out in the kind of Podunk kind of panhandle area of Florida, and they had a well. Again, they weren't on city water; they were on well water, and they actually had a lead contamination in there. And there's 3 kids of I think one was an infant, one was 2, one was 6, and then the parents. It was interesting because you'd actually see that the youngest kids would have the highest lead levels because they would actually hold on to it the most because they have the most actively developing bones, versus the adults may not hold on to it as well. They can eliminate it a little bit better. But anyway, so be very careful. Make sure little kids get their calcium supplementation. Helps to limit that exposure there. Anyway. So calcium, vitamin D, we already talked about those being really important here. We'll talk about the bisphosphonates. These are going to kind of be our gold standard for many of these patients. We'll talk about estrogen agonists or antagonists, our SERMs. We kind of mentioned this as well back in the OB-GYN section. And we'll talk about calcitonin, denosumab, estrogen, and testosterone more specifically. So as far as bisphosphonates go, we have several that are available. We have alendronate, ivandronate, residronate, and then zoledronic acid. Important to know that this one is going to be IV only. Most of the other ones are going to be oral tablets that the patients can take, but a lot of times you may find that due to compliance issues, or if they're not able to tolerate this, they may go with the IV route. Anyone know how often you have to give zoledronic acid? Actually yearly, so that's kind of another benefit. You only have to give it one time a year, and you're basically done for that period of time. Anyway, Basically, what these drugs are doing is they're trying to actually mimic this product called pyrophosphate. It's actually an endogenous product that is a bone resorption inhibitor. So it's a natural product that the body produces to help decrease osteoclast activity and increase some osteoblast activity. And so by giving these drugs that look similar to that, it's able to get incorporated into the bone and able to kind of stave off that resorption from happening there. So these drugs are not very bioavailable, so less than 1% bioavailability when you take an oral tablet of one of these medications. And so you got to be really careful, and it's really important they're educated well on how to receive these drugs. So did you guys cover this at all? How they should take these bisphosphonates? Yeah, so it needs to be like right in the morning, right when they get up typically. It needs to be a full glass of water. And no other beverages, no milk, no food on board, because it will help to decrease that less than 1% bioavailability to almost nothing, right? So it needs to be separated out from everything else, basically. And the patient needs to stay upright for a period of time, maybe like 30 minutes, an hour, to make sure that it actually gets absorbed. These tablets tend to get stuck in the esophagus, and you can actually see some esophageal erosions actually happen with that one. So again, if a patient has issues, especially like dysphagia, or if they're not able to get these down and be compliant with that, because again, for some patients it may be difficult to keep them up for that period of time, these are not going to be good options. The IV zoledronic acid may be a better option for them. They can be very, very aware. They need to take these separated out, not with food, not with milk, not with coffee, glass of water, stay upright for 30 minutes to an hour, that's it, right? Anyway, and they actually get incorporated into the bone, so they stick around for a very long time. So they have a biological half-life up to 10 years, and that's why it's very difficult for kids that have like lead toxicity to get rid of that lead, because once it's in the bone, like it kind of doesn't go away for a good long time. Just like calcium shouldn't really be going anywhere. So anyway, as far as adverse drug reactions go, again, a lot of GI upset with this one. So you have some heartburn, some dyspepsia associated with it. And I mentioned that esophageal erosion and ulcers that can form if the tablets actually get stuck in the esophagus. So again, just with a big glass of water, that's kind of it. And then one other kind of unique side effect from the bisphosphonates, and this may be related back to bone turnover, but one of the things you can see is actual osteonecrosis of the jaw. So you can see some pretty gnarly pictures if you Google that. But that is one kind of unique side effect you may see with the bisphosphonates. Okay, so I mentioned take oral tablets with 6 to 8 ounces of water is fine. No other liquids. It needs to just be water. That needs to be it. And again, at least 30 minutes before consuming other foods or liquids. So try to get that time to separate out. Try to get into the stomach and get absorbed the best it can. It really needs to stay upright. Okay. Now the dosing is going to be different based on the product you're dealing with. It could be daily. Some of these are going to be more like weekly, monthly, and I mentioned the zoledronic acid. You only have to give like say once a year or something like that. So again, it can be beneficial from a compliance standpoint. And they should go in, get the infusion, and they're kind of done for that year. It can be nice. Next, you have denosumab or Prolia. This is actually a monoclonal antibody, as you can tell by the name there, MAB. It actually binds to this rankle protein. It's probably one of my favorite named proteins that are out there. But rankle actually binds to this rank receptor on the surface of the osteoclast. And so if I can try to bind up this rankle and prevent the activation of that rank receptor, you actually will find decreased formation of these osteoclasts, right? So instead of it binding the precursor cells and then developing the osteoclast, kind of helps to interrupt that whole process there. So that can be utilized, especially if the patient can't tolerate a bisphosphonate for whatever reason. And this one, again, has to be given sub-Q due to the fact that it's a monoclonal antibody. Oral would not be a good option here. It does stick around for a decent period of time. Given every 6 months, so good from a compliance standpoint. Only have to give it that often. And as far as adverse reactions go, you may see some local dermatologic reactions, just like with anything you're injecting for the patient. Some risk for skin infection, and you can see it's bone turnover suppression. Clinically, I don't know what that actually kind of manifests as. That's a big issue, but they do say to watch out for that. You may see suppression of that bone turnover, mainly because you have a pretty significant reduction in osteoclast activity, but you still have osteoblasts still kind of sitting there putting on bone. Okay. Next, we'll have the mixed estrogen agonist antagonist. And we talked about these previously in OB-GYN, so I'm not going to kind of cover these here in great depth. What do you think? What are the side effects you could run into with something like raloxifene? You wouldn't have fractures with this one. That's the nice one because it would actually act as an agonist for estrogen receptors in the bones. This is actually going to be could be used to prevent osteoporosis as a good supplement for that. Tamoxifen, though, you could definitely see something like that, and certainly the aromatase inhibitors, anastrozole, letrozole, you could definitely see risk for fractures there because this actually deplete estrogen levels. But what side effects did you see from acting as an antagonist in other tissues? menopausal symptoms, right? So you can see the hot flashes, those vasomotor symptoms, vaginal dryness, things like that. So again, just keep in mind those symptoms you can, side effects you can come up with those drugs. Hopefully didn't dump everything from the last test. So if you retained at least a little bit of it, that'd be nice. Okay, the next one we have is calcitonin. This is actually working via a different mechanism here. So this one's going to be not typically used as like a first-line agent for osteoporosis. However, if a lot of other therapies are not really useful, this can be utilized. And so this is actually it's an endogenous hormone. Our body naturally produces calcitonin, but it actually antagonizes the actions of PTH, parathyroid hormone. So this is kind of the flip side of PTH. You have calcitonin. So if you had to imagine, parathyroid hormone does what to calcium levels? Should increase it, right? Because it increases bone resorption. So calcitonin would do what to calcium levels? Should decrease them, right? Because you would see that it would actually help to inhibit osteoclast activity. Because again, opposite effects of PTH there, so it would actually decrease calcium levels. You may see this being used with like Paget's disease and things like that. Bisphosphonates may be used for that as well. However, what's interesting is we don't have a good way to produce it. So the stuff we get is actually produced from salmon sperm. So whatever reason, salmon sperm happens to have high levels of calcitonin, and that's where we get our drug from. So again, I don't know who the scientist was that figured that out. No judgment, but this is how we get the drug. And interesting, we actually administer this one intranasally. So there's a calcitonin nasal spray that they'll use related to this. And so again, not first line, but you may see it used for other things like hypercalcemia. You may see it used in Paget's disease more commonly there. But again, this is another agent we have available. Again, because it doesn't have as good evidence for reducing risk for fractures. So again, here it says risk for vertebral fractures reduced, but not hip, right? So again, you kind of want the full scope there as far as kind of reducing all fractures if possible. We'll talk about this more when we get to hypercalcemia in the endo section later on. So just kind of keep that in the back of your mind. We have teriparatide or Forteo. This is going to be one, again, not used as first line, usually used if they can't tolerate these and bisphosphonates and other therapies. But these are going to be good for high-risk patients to develop fractures who fail bisphosphonate therapy. So they can't tolerate that. It's not working for them. This is a good backup to that. And this one's actually interesting because it's actually the first 34 amino acids of parathyroid hormone. And normally you think if you have high parathyroid hormone activity, you would see worsened osteoporosis. But for whatever reason, if we get just kind of a snippet of that, the first couple of amino acids, you actually will find that it will help to more stimulate osteoblast activity than it does osteoclast activity. So from that standpoint, you have better bone kind of deposition than you have resorption that's occurring there. So kind of shifts the balance away from the osteoclast and onto the osteoblast, which is beneficial for them. However, it's not going to be perfect for everyone. There's actually a RIMS program. So again, big risk side effects associated with this one, and this is going to be bone cancer risk. And that makes sense because if your osteoblasts are going to be working in kind of an overdrive due to the stimulation, you can see chances for those cells to kind of start to kind of grow on their own, risk for bone cancer. And so they actually recommend patients take this for less than 2 years. Any more than that, and that risk becomes kind of the risk then outweighs the benefit potentially. Okay, so again, a lot of this is just going to be based on things like your bone scans and different risk for fractures. But typically, what you're going to find is that if the patient has normal bone mineral density, but they're getting a higher risk for developing osteoporosis, obviously the first thing you always want to start out with is going to be bone healthy lifestyle, getting exercise, calcium, vitamin D supplementation. Those are going to be the first big things you want to initiate on any of these patients. And then, based on their bone mineral density, how the scores are coming back, then you need to look at using something like bisphosphonates. I'm trying to see where those come in at. Those come in at right around here. So using the oral agents is usually going to be a good option for most patients. Again, education is going to be really important to make sure they're taking that appropriately, because you may find that you prescribe alendronate for them. They come back, their bone mineral density is not getting any better, it's getting worse, and you're like, okay, well, are they taking it? Like, yeah, of course I'm taking it. Next question is, well, how are you taking it, right? Are you taking it alone on empty stomach with water? And they're like, no, I'm actually taking it with a big glass of milk. I'm like, I got it. Okay, so now you're not absorbing the drug at all. That makes better sense. Okay, so these are questions to ask, make sure they're taking it appropriately. And then obviously, if they have things like they're menopausal, having something that helps to replace those estrogen effects can be beneficial. So either hormone replacement therapy, which obviously is not without risk. We know some issues with that, but maybe a SERM like raloxifene could be good from that standpoint, because it acts as still an antagonist of the breast tissue, an antagonist in the uterine tissue, but it'll act as a agonist in the bone. So it can be one option to use for that. And then again, they are failing those drugs. You can think about things like teriparatide. You can think about things like calcitonin, but usually vitamin D, calcium, bisphosphonates are going to be your kind of go-to for those patients. Make sense so far? Okay. Any questions on that? All right, now we're going to talk about gout. You guys talked about gout? Already? What do we use for gout? Colchicine. Anyone know where you get colchicine from? The plant-based product. The autumn crocus. These are random facts I learned as part of my fellowship. Anywho, what else can you use besides colchicine? NSAIDs are good. Anything else? Allopurinol, yeah, that'll be another big one we're going to talk about. Good. So you're already familiar with some of the important drugs we're going to use for this. If you had to overdose on one drug, I can tell you right now, colchicine is one of the worst. Fortunately, I've never seen a colchicine overdose, but if I did, it would probably be near fatal. It's a very, very bad drug to overdose on. We'll talk about why that is in just a little bit. Anywho, so gout, kind of a spectrum of diseases, kind of including this hyperuricemia is kind of the main issue we're seeing here. And basically, you're having this acute arthritis related back to these monosodium urate crystals, right? So these are going to be kind of precipitating out the synovial fluid. It's going to be causing a lot of pain and issues associated with that, causing a lot of inflammation. And so you can see this not only in the joints, but they can kind of start to precipitate out in surrounding tissues. And so in addition to that, you also see some nephrolithiasis and some interstitial renal disease that can develop from this as well. So again, not just related to the joints. And again, if it had to be a joint that was going to be affected, what do you classically think of? The big toe. Think about the big toe getting affected. I remember like seeing these like old pictures from like olden times where like little devils like poking a guy in the big toe with this little pitchfork. That's what it feels like. Very, very painful for these patients. But think about the nephro issues that can happen from that. Think about the other soft tissues that can be affected by those crystal deposition. Anyway, so basically what we're seeing is that uric acid. Where do we get uric acid from? It's a waste product, right? That's where we're generally trying to pee out in a lot of cases. It's usually a breakdown of things like purines. And so can you imagine anywhere where we might have a lot of breakdown of purines all at the same time? Any particular disease state, maybe we're trying to kill off a lot of cells all at the same time? Cancer, yeah. So there's actually, you can run into issues where, especially with like leukemias that are, your white cell count is extremely high, and you give them medication to try to kind of wipe them all out relatively at the same time. You can have a lot of purine waste that gets spilled out there, and you can have what we call tumor lysis syndrome. Have you guys heard of that term before? That can develop from that, and this is a big issue because, again, the kidneys can take a big hit here. We'll talk about one drug that you can use to help combat that, but again, that's another case where kind of related to gout, but not specifically the same thing there. But basically, the way you may see increased urate pools, more urate being produced here, and again, the higher levels are, the more likely they are to precipitate. If you have issues of overproduction, so if you have maybe like some enzyme abnormalities, we're going to see that things like xanthine oxidase are going to be important enzymes when treating gout. You have issues where you have increased breakdown of nucleic acids. That's kind of mentioned that tumor lysis syndrome, or if you have like these excessive cell turnovers. Those would all be cases where you have a lot of purines that are being produced, but also being broken down and trying to be eliminated. You could also have underexcretion from the kidney, so this could be related to either idiopathic issues or related back to things like dehydration. So you may find, especially if you have higher levels of urate and then you get dehydrated, you're concentrating that further, that can lead you to being at bigger risk for having that precipitate out, right? So our goals, we like to treat the acute gouty attacks if possible and try to prevent any kind of recurrent episodes of arthritis. And then we have to prevent any kind of long-term complications, usually from that kind of chronic deposition in the soft tissues. You're going to find that the main therapies are going to kind of be broken up into two halves here. So we'll have the anti-inflammatories and we'll have the urate-lowering therapies. Again, which ones do you think are going to be better for kind of acute issues? Yeah, the anti-inflammatories, the analgesics are going to be better for kind of acute gouty attacks. The urate-lowering therapies are going to be better for kind of chronic maintenance of this, to try to prevent an attack from occurring in the first place, right? So kind of getting that mindset of thinking, okay, what's good for the acute attacks, what's good for kind of chronic maintenance to prevent attacks. All right, so non-pharmacologic, we can try ice, but again, these are very, very painful manifestations usually, not always going to be perfect. So we can use things like NSAIDs, can be very beneficial here. We'll get more into depth on NSAIDs when we get to the orthopedic section coming up. And then corticosteroids can be used occasionally. We'll talk about those, but again, potent anti-inflammatories. This is something you take daily, do you think, for gout? No, this will only be for like really acute attacks. Again, very short course, kind of pulse therapy, beginning with that. We'll talk about colchicine. And typically you want to start therapy earlier the better. Usually in the first 24 hours is going to be most beneficial. And you may find that you need combination therapy in a lot of cases, maybe colchicine plus an NSAID or something like that, or a glucocorticoid plus an NSAID might be useful, especially if it's multiple joints being affected, or if it's really kind of severe issues of pain. So we'll look at the pain management slides a little bit later, but NSAIDs we'll cover that in more detail. Again, think about common adverse effects, and usually this is going to be kind of the limiting thing for a lot of patients getting NSAIDs. Usually the GI effects, usually the renal effects, or the usually bleeding is not such a big issue, but the GI effects are going to be one of the big things that precludes a lot of people from utilizing NSAIDs. But corticosteroids, generally going to be equivalent efficacy to NSAIDs, and you can utilize actually either orally administered ones, which you see a lot of systemic side effects from, as you might imagine. On some occasions, they may actually use intraarticular injections. So you can use something like triamcinolone acetonide or Kenalog, and so that can be injected directly into a joint. Better if it's only a small number of joints being affected or just one. They can get away with that. And again, nice local therapy, very, very potent anti-inflammatory right at the site of action, which is good. But again, more than 2 joints, probably going to need some systemic therapy. So like an oral corticosteroid would be good. It's not usually so severe that you would need to have something like IV steroids being administered here. Usually oral would be fine for most of these patients. And again, if they need to be on it for more than a week, you need to taper down off of that, right? So again, if you're only giving them 5 days worth, probably no need to have a taper, but it's much longer than that. Yeah, I certainly want to build that in. Or give them something like a Medrol dose pack that already has a taper kind of built into it right from the packaging itself, right? Remember what kind of adverse effects can I expect to see with corticosteroids? So immunosuppression is a risk. Not usually you're going to see with necessarily with kind of this short course, but is it a risk? Hyperglycemia, yep. So the diabetes, you have to worry about the sugars getting worse. Any eye stuff? And glaucoma can be worse in there. Cataract formations, that's usually more chronic. Anything else? What about their blood pressure? Probably go up, right? Because again, you can see some of those mineralocorticoid effects. You see some of that fluid retention that can happen there, right? Remember, think back on these things. These are common things. Any CNS manifestations? Some people get very cranky when they're on corticosteroids. They can have, a little bit of altered mental status there. So again, watch out for that. And again, think about these are sometimes older patients that are dealing with this. So again, are they having worsening dementia? What's going on? Or is it that maybe the steroids we put them on is causing them to act a little bit more loopy than usual? Right? So there's things to consider. Trying to keep you on the edge of your seat where we talked about colchicine. You're like, wow, is that deadly? It is that deadly. Watch out. Okay, so why would it be so dangerous? Well, it's an antimitotic drug. You remember any other antimitotic drugs we've talked about previously? Cancer, yes. You remember any of the ones we talked about? Starts with a V. Yeah, Vincas. Yeah, the Vincas did it, right? Yeah, the Vinca alkaloids were big ones. There was like etoposide, right? The topotekins that were also involved with that. So again, this is working on just a different part of the microtubules essentially. So I don't know if this has any history of use for cancer. It doesn't not used currently. However, gout's the main place you're going to see a lot of colchicine being used, and so it's antimitotic, which means it helps to prevent a lot of that cell replication, right? So again, it helps to prevent from the pulling the chromosomes apart aspect of it, but also those microtubules get used in all sorts of provides that cytoskeletons. It has a whole lot of functions there. However, in gout, we're going to see it actually helps to bind to some of the proteins there, the microtubules and the neutrophils specifically, and this will help them to prevent them from getting to the site to cause that inflammation. So prevent that migration, and if you will see less of that tissue deposition, because again, those neutrophils are going to try to kind of engulf those crystals. But you can see that can cause further damage and inflammation to cause there. So typically these are only used for acute gouty attacks. So typically you're going to find that the longer it goes on for, the less efficacy is going to be had. And that makes sense because if it's been more than 36 hours, all those neutrophils have already been kind of moved right to the site of inflammation. It's not going to be as beneficial. So if you can give it earlier, usually the better it's going to be for your patients. Now there's a lot of side effects associated with it. And actually what's kind of interesting is they used to dose it based on the side effects. And so basically you would keep taking a dose every so often until you threw up, and they said once you throw up, either your gout attack goes away or you throw up. I was like, that's kind of odd dosing. It's giving yourself the toxicity is a sign of when to stop. Okay, well, I guess that works. Hopefully you guys don't do that with alcohol on the weekends or something like that. You keep doing it until your feelings go away or you throw up. Don't do that. It's not healthy. Fortunately, we don't do that quite as often anymore. It's a little bit better dosing. It's available now. But a lot of nausea, vomiting, diarrhea associated with this drug. And again, this kind of makes sense because if it's helping to inhibit replication of a lot of rapidly dividing cells, where are the rapidly dividing cells? The GI tract, right? Because we're constantly replicating those, or constantly having those cells divide, try to replace the GI epithelia. So you can see some issues with that. So a lot of nausea, vomiting associated with that. And then more, you can see this with kind of longer term dosing. You can see neutropenia because again, the more white cells are constantly dividing. And then actually you can find some damage done to the nerves over time. So you have these kind of peripheral neuropathies that occur secondary to these some of the damage done to those cells. And so actually what you end up finding is if you had someone who had overdosed on colchicine, you'd really worry about, it's not the colchicine itself that would kill them, but certainly they'd have a ton of GI issues that would develop there. But it's usually the myelosuppression that happens, and they would actually have an overwhelming infection due to their white cells just being completely wiped out, essentially, due to that. So again, don't overdose on colchicine. In fact, I don't say it used too often, but you'll see, if you have a gout patient, if it works for them, it probably works great, and that's all they'll need in some cases. So anyway, based on the pain intensity the patient is experiencing, this will kind of guide you into choosing what type of therapy you're going to use. If it's kind of mild to moderate, I would probably say go with an NSAID first line if they can tolerate it. If they're kind of low cardiovascular risk, they have no kidney issues, no GI issues, I say go with an NSAID. Otherwise, you can use things like your colchicine, systemic corticosteroid. Those would all be decent options. However, if it's kind of more severe, this one combination therapy is going to be more preferred. So you can use things like a colchicine plus an NSAID or a steroid plus an NSAID. Some cases maybe like colchicine plus intraarticular corticosteroids. You have all kinds of options there. And then basically you want to eventually get to monotherapy if you can, right? So they can get to a point where they can just use one drug that's going to be beneficial to help limit some of those side effects. And then you may find that you also want to kind of focus on the non-pharmacologic stuff. So you can try to prevent these gouty attacks by helping to reduce that uric acid pool. That's going to be beneficial for them as well. So what do you think we could do to dietary modifications to decrease? Yeah, decrease alcohol, that can help with like dehydration issues, but where do we get a lot of purines in our diet? Protein, yeah. So we can have a lower protein diet. That can actually be a big thing to help lower those urate pools, right? Anyway, so lots of things we can do with that. And in some patients, if they kind of know, if they can kind of self-treat, they kind of know when they're going to have a future attack. Sometimes if they can know when it's coming on, they may come or may have a script available and fill it. Say, take a corticosteroid if they know it works for them. Here's 3 or 5 days worth. Have it home ready for when you have the attack, right? Or have an NSAID available or colchicine available for when you know it's going to be coming on or when it starts to come on. Because again, the earlier you can start treating this, the better off you're going to be for those patients, right? So that can be very beneficial. But sometimes the first one, they don't know about it, then they may need to come in to see you to get these started first line. Anywho, on the flip side, dealing with the hyperuricemia, you're going to find that we can use drugs to help maintain kind of lower uric acid levels, kind of a baseline. Again, mentioned that lower the alcohol intake can be beneficial here as well. And then if we can lower or kind of eliminate drugs that will increase uric acid levels, that can be beneficial. So thiazide and loop diuretics, you end up finding that this can increase uric acid. You'll find that it will compete for transporters within the renal tubules, and so that can lead to uric acid levels increasing. So if you can get them off a diuretic, that can be useful. Also, diuretics will do what to your fluid status? Should dehydrate you, right? So that can put you at higher risk for having that precipitation. Niacin's another big one. Remember we saw niacin being used? Yeah, hyperlipidemia, right? It's good for getting your triglycerides down, raising HDL. That also can increase uric acid levels. So that's another thing to watch out for. And low-dose aspirin can do this additionally. So again, just try to avoid those medications if possible. Sometimes you have to have them on anyway, and we can use drugs to get around. So our urate lowering therapies pretty cost effective, especially for patients who have kind of more recurrent attacks. So if it's like 2 or more than a year, then I would go ahead and put them on urate lowering therapy to try to help prevent the attack from occurring in the first place. Also consider, if they have, more than one tophus is present, if they have chronic kidney disease, urolithiasis, any of these are kind of like high risk issues you don't want to, aggravate. Putting them on urate lowering therapy can be beneficial for them as well. And so we can either do things that will help to decrease synthesis of uric acid, and this is where our xanthine oxidase inhibitors are going to come into play. Remember what that was? Yeah, allopurinol is going to be our main xanthine oxidase inhibitor, and then we're going to have things we can use to increase uric acid excretion, or uricosurics. So basically you just pee it out at a faster rate than normal. So this is the xanthine oxidase pathway. Again, this is how we're basically developing uric acid. Again, just remember most of these steps, be able to kind of reproduce it. I'm just kidding. Don't worry about that. Big thing I just want to focus on here. Here's where xanthine oxidase comes into play here. This is going to be helping to prevent conversion from hypoxanthine to xanthine and then xanthine to uric acid. So if I can inhibit this process, even though all this is still going on up top with these nucleic acids getting broken down, you can help to prevent uric acid from being formed, and you can basically just pee out the hypoxanthine. It's not going to be nearly as big a risk for it precipitating out and causing gout, a gouty attack. Okay. So basically, the two big drugs we're going to have here include allopurinol. This is a very old school drug. It's been around for a very long time, so it's pretty cheap. A lot of patients will end up utilizing this. And then we'll also have febuxostat. This is actually a much newer agent. I believe it's still brand name last time I checked. And so, again, more expensive in a lot of cases. However, the reason why you may use febuxostat versus allopurinol are due to some of the side effects you can see with it. So rash can be one thing you'll see with allopurinol. You can see this toxic epidermal necrolysis. And pretty bad dermatitis associated with that. Kind of think about TEN with Stevens-Johnson syndrome and that kind of same category of kind of skin manifestations. Definitely an immediate discontinuation sort of thing. Go to the ER, get managed there. Also see some leukopenia associated with this as well. However, with the febuxostat, much better tolerated for the most part. It may have some arthralgias, transaminitis, but other than that, it's very well tolerated. So again, probably start with allopurinol if they don't tolerate that. Try febuxostat as an alternative. So, and then we'll have our uricosurics, and so these are not used quite as often. I see a lot more allopurinol being used rather than using probenecid, but this is one where it will actually cause a risk for having nephrolithiasis, and that kind of makes sense, right? Because if I'm increasing the amount of uric acid being sent out to the renal tubules, they're more likely to precipitate out there. So that's one risk you run into with using something like probenecid. And so again, this might be one of those things where have therapy available in case they induce an acute attack, or maybe if they're on like a xanthine oxidase inhibitor beforehand, this will help to kind of stave this off from occurring here. Now, what's interesting is probenecid used to be used for a long time to actually help increase levels of other drugs, and so namely the penicillins and cephalosporins. It would actually help to inhibit renal secretion of these drugs. And so back in the day, and you guys know where we originally have penicillins and cephalosporins made? Yeah, mold, right? So again, we didn't have a good way to actually produce, and again, this is like decades and decades ago. We didn't have a good way to produce our own penicillins and cephalosporins, and so it was difficult to get. They're very expensive, so we needed to find ways for it to stick around the body for longer. Because again, are these concentration or time-dependent antibiotics? They're time-dependent antibiotics. Remember, they want to stay above that MIC for as long as possible. So if I could give a drug that kept the drug in the body for longer, that was going to be beneficial, very cost-effective, and for a difficult-to-produce drug. And so this is why I used to give probenecid along with penicillins to keep those levels up for longer and get better antibacterial activity. We don't have to do that anymore nowadays, but again, it's an important drug interaction to be aware of. Probenecid typically will increase levels of the drugs by preventing their secretion into the renal tubules. And this will be contraindicated in patients with renal impairment. So in those cases, allopurinol will probably be a better option for them. One other drug you may see being used, this is called rasburicase or Elitech. This is actually a recombinant form of uric oxidase. So this is actually an enzyme that can directly cleave uric acid into more water-soluble forms. And so this is a drug we may use for tumor lysis syndrome. So if you have someone who had a significant leukemia, you gave them chemotherapy to try to kill off those cells, you will find a huge amount of uric acid being produced. You can give rasburicase to actually go in and cleave it and allow those levels to drop pretty precipitously, and they can just eliminate the more water-soluble byproducts on their own. So very, very expensive, many thousands of dollars for this medication because it is kind of a recombinant protein we're having to make here, but it can be life-saving for some of those patients. So just be careful of that. Or be aware of that. Some patients that have to get repeat dosing, they can develop antibodies against this, so it may make the drug less effective, or they may develop an allergy. So that's one thing to consider. So if you ever work in hem-onc, this is probably a drug you'll become familiar with, especially in peds hem-onc, where tumor lysis syndrome is a concern with a lot of the leukemias that they develop there. And then anyone familiar with G6PD deficiency? We haven't really talked about it too much here. What is that? It's an enzyme, yeah. So G6PD is an enzyme utilized. I don't know what it does. Breaks down something? Not really, actually. This one that doesn't break down anything. You're close. I mean, you could have probably had like a 50-50 chance if I'm asking the question. Not with sickle cell, not, at least not that I'm aware of. But one of the things it does is actually it helps with redox reactions with namely hemoglobin. And so one of the things that you'll see is the iron itself it can go from a 2+ to a 3+ state based on how much oxidative stress is in the system. And so when you have G6PD, that can actually help to convert that back to the normal 2+ state. When it's in the 3+ state, it doesn't like to bind to oxygen very well in hemoglobin. It actually binds to water. And so they develop what we call methemoglobinemia. So it goes from hemoglobin to methemoglobin, and it is not super efficient for your patients to carry oxygen around because it's holding on to water. And so anyone know what color it turns your patients? Turns them blue, yeah, so it looks like a Smurf basically. So some patients are G6PD deficient and they can actually develop this methemoglobinemia. Again, I'm not going to test on this, it's just kind of an interesting side point. But for certain drugs, you have to watch out for patients who are G6PD deficient because worst case scenario, you can cause hemolysis for them and all of a sudden they're lysing all these red blood cells. They may need to exchange transfusions, it can be very bad. And again, not a lot of people know if they're G6PD deficient. It's not until they usually have an issue that they'll actually find this. All right. So looking at using urate lowering therapy. So again, if you have someone who has like kind of multiple gouty attacks, usually going to be a good candidate for that. Or if they have kind of any kidney issues associated with uric acid, these are patients that are going to benefit from urate lowering therapy. Again, typically you can utilize first line xanthine oxidase inhibitor like allopurinol. It's usually going to be most beneficial for them. In some cases, you may need to use multiple agents, but for the most part, one is going to be good. And you're going to monitor those uric acid levels over time to make sure you're kind of achieving appropriate levels there. It's probably going to be as far as we're going to get with it, but just remember they will probably have kind of as needed prescriptions for anti-inflammatories, but they'll be on something like allopurinol kind of consistently. You can maybe try to take them off of it, especially if they get their diet under control and kind of fixes other issues. However, if not, then they may be on the allopurinol, say, forever. But the PRN medications from the inflammation should be utilized at the onset of the acute gouty attack. That way they can get better effects kind of earlier on they initiate therapy. Okay. Any questions on that section? All right.